My name is Dr.Ida. I'm a consultant rhinologist from Hospital Sultanah Bahiyah, and mainly I'm dealing up here. I didn't go further down, okay? But what am I doing in this conference of reproductive endocrinology, endocrine reproductive? I was invited to discuss about obstructive sleep apnea. Okay. How many of you snores here? Put up your hands. Yeah, I can see some. I know you. Okay. I will start off with a video just to show you, or maybe I suppose all of you know how snores sounds like or how snores looks like, but have you ever observed a person sleeping recently? Okay, let's just have a look, have a listen to this. Suara okay? Okay, so that's how a snoring sounds like and look like. And you notice that towards the end of the video, this patient actually chuckled with that sounds, yeah? Okay, so snoring is actually produced, a sound that's produced during sleeping due to a partial obstructions of the upper airways. Okay, and in normally, the air will flow through an patent airways, but in a partially obstructed airway, the flow of the air will be turbulent, and with the vibration of the uvula and the soft palate, that the soft tissues inside the oropharyngeal area, it will produce a sounds that snores. Okay, and about 40 to 60% of adults in the worldwide do snores. Yeah? It can be a simple snoring. Yeah? Or it can be part of the obstructive sleep apnea symptoms, and most commonly, snores are most commonly noted symptoms in OSA. Sleep disorders from ICD-10, actually the sleep disorders covers a very wide range of conditions or situations. So where does the OSS falls into these sleep disorders? Dysomnias, or the disturbance of the normal sleep patterns, then can be due to extrinsic or intrinsics. If you have a look here, the OSA falls into the sleep disordered breathing. If you can see, the sleep disorders can be due to any psychological disorders or neurological disorders, movement disorders, or even the extrinsic. Yeah? And even all of these can contribute to obstructive sleep apnea. So, what's the normal pattern of a sleep? We mammals, human, we usually sleeps about 8 hours. That's our so-called effective good sleep. Sorry, I think it's run out of batteries. The pointer. Okay. So normal sleep usually have a non-rapid eye movement and a rapid eye movement. The non-rapid eye movement is divided into further stage 1, 2, 3, and 4. While the rapid eye movement, it has got the characteristic of characterized by starting to have a dreams, and the eyes move rapidly under the eyelids. And also, there's a decreased muscle tone of paralysis. Before we further embark into OSA, I would like just to go through some terminologies. the apnea. Apnea is actually a cessation or stoppage of flow of air about more than 10 seconds. These numbers is very important. And in obstructive sleep apnea, there is a cessation of airflow for at least 10 seconds with respiratory effort. And you can see the difference with the central apnea. That is a cessation of airflow for at least 10 seconds without a respiratory effort, right? And another terminology is hypopnea. There is a reduction of airflow by 50% or more, lasting more than 10 seconds. Why are these all terminology important? Later, you will see in the sleep study analysis. And apnea hypoapnea index, or AHI, is the parameters that we use to quantify the severity of OSA. We have a mild, moderate, and also a severe OSA. Yeah? So OSA is symptomatic individuals with a cessations of airflow in the presence of a continued respiratory effort for at least 10 seconds. The cessation is at least 10 seconds, which is occurring during sleep of more or at 5 or more times per hour. And usually it's accompanied by saturations of oxygen, desaturations of the oxygen of less than 90%. Again, obstructive sleep apnea, the words are repetitive episodes of upper airway obstruction that occur during sleep and usually associated with reduction of oxygen saturation due to apnea and the constellation of symptoms including loud snoring, fragmented sleep, and excessive daytime sleepiness. If you are male, you are obese, and you are under the categories of 5 to 7 series, you are at risk of developing OSA. Okay, and the epidemiology that it says that 2 to 4% of population actually have OSA. This is a Malaysian data, which we think in our centers the percentage is rather too small, yeah, because it's mostly underdiagnosed, mostly underreported. So diagnosing OSA is actually like a tip of the iceberg. We only diagnose only a minimal number of patients, but actually the OSA remains undiagnosed. So this is just an overview of our own experience in Hospital Sultanah Bahiyah. We have OSA clinic. About 139 adult patients of confirmed OSA, and about pediatric, about 15 patients. And of these numbers, 61% are male and 38% are female. And most of them are obese, where BMI is more than 30. In our center, we have a pediatric ORL. So we do have referral cases for pediatric age group that's diagnosed with OSA. The main risk factors for obstructive sleep apnea is obesity, and it says that BMI of more than 29 are 8 to 12 times more common than BMI of less than 25. Okay, and it also associated with the neck circumference, where males, if it's more than 17 inches and you are snoring, you are predisposed to OSA in 30%, and female also if the neck circumference is more than 16 inches. And again, the age and the gender. There's another video that I would like to share with you. In the first video, you notice that the snoring is not that bad. But in this video, I would like you to observe the pattern of sleeping. When the patient starts to stop breathing, you can actually see it there. And how long it stops breathing, that is when apnea, and when we consider as OSA, the cessation is more than 10 seconds. Yeah? This is, the video is taken when we are doing a sleep study analysis. And you can see that there is straps in the abdomen, straps in the chest, cable over the chin, so it's a louder voice. You can see here, straps in the abdomen and straps in over the chest, and now the patient has stopped breathing. And you notice also is oxygen saturations being recorded, a chin movement, nasal airflow, is the electrodes for detecting the eye movement, and also EMG over here. So it's definitely more than 10 seconds. Yeah? You can see that the patient is not breathing, only the abdominal movement here. And that's arousal, and you can see the patient is actually struggling to get some air. Okay, I may have to forward a little bit until here. And again, it's a repetitive cycle. The patient stops breathing again, and at this time the oxygen saturation drops, and there will be an arousal again, and you can see the limb starts moving. So during a sleep study, patient will be admitted to our ward, and we'll have all these strips over the patients, and we'll record the parameters that we needed. So when patients start snoring due to partial obstruction, and towards and then we get apnea, that is a stop breathing, where there is a total obstruction, and then there will be a struggling of air, and there will be arousal due to sympathetic activity, and it will recycle again. So this sleep apnea cycle causes a cyclical hypoxemia, which predisposes patient to a systemic hypertension. Okay. And also, you notice that there will be a sleep fragmentation that will also lead to a daytime cardiovascular and neuropsychological consequences. So the obstruction can be from the nasal cavity or the nasopharynx area, from the oropharynx, or from the laryngopharynx area. Fujita in 1987 classified the obstruction into retropalatal, where it is behind the palate, and also retrolingual, where it is behind the tongue, or both, behind the palate as well as the tongue. And this is important in terms of to identify which part of the airways is obstructed. So the clinical assessment includes a full history, physical examination, and some diagnostic tools like the scopes here, and also the gold standard for diagnosing the OSA is PSG, that is polysomnography. In the history taking, usually we interview not only the patients but also the spouse, because most of the time the patient may not be able to tell you what happened during sleep. So the spouse is the one who witnessed what happened during the sleeps. Yeah. So nighttime symptoms include loud snoring, frequent nocturnal awakenings, choking or gasping during sleep, drooling or bruxism, clenching the teeth, and enuresis, and a decreased libido or erectile dysfunction. And daytime symptoms will include daytime sleepiness, like neurocognitive impairment, morning headaches, and dry mouth, because patient has a blocked nose, so they tend to open up their mouth to breathe in and out when they sleep. And unproductive at work or at school, fatigability and mood change, and also accident prone. And other clinical history that you should be able to be aware is what predisposed patient. For example, in patient with allergy rhinitis who have hypertrophy of inferior turbinates, acromegaly who have a big tongue, hypertension, cardiovascular disease, congestive heart failure, these are all has to be included in the clinical history. one of the tools to screen a patient with OSA is using a Epworth Sleepiness Scale. Maybe you can start counting, answering this question, and see how much you score yourself. Yeah? This is actually a very subjective way of screening a patient with OSA. The chance of dosing is rated from 0 to 3, where 0 is never dosed, 1 is slight chance of dosing, number 2 is moderate chance of dosing, and 3 is high chance of dosing. So, for the past 1 week or so, in a situation like sitting and reading, how easy will you get to fall asleep or doze? So you tick here, if you have 2, 2. So if you completed the questionnaires, for score more than 11 and above is a risk of OSA. Okay? This screening tools is also used in the modalities to actually monitor the progress of patient after we start on treatment. So how many of you have more than 11? Wah, banyak juga ya. So you can come and see me afterwards. The other way of screening method is stop bank questionnaires. Some centers use this as well. In stop bank questionnaires, we ask patients and we answer the questions following as yes or no. And if it's 3 or more, yes, then you are high risk of developing OSA. If you have less than 3, then low risk of developing OSA. But again, this is just a screening tool and it's very subjective. So S for snore, T for tiredness, O for observed. Has anyone observed you stop breathing during your sleep? P is for pressure, high blood pressure. B is for BMI, is more than 35 years. A is the age, if you are more than 50 years. N is the next appearance, and G is the male gender. Okay. So this is how an office looks like if most of your pekerja-pekerja is actually having OSA. So PCOS is the most common endocrinopathy which carries a significant metabolic syndrome, type 2 diabetes mellitus, dyslipidemia, and insulin resistance. This all has been covered by Dr. Shafinas and also Dr. Hatta just now. In the reproductive age group of women with PCOS, they are at a very elevated risk of OSA compared to women without PCOS. And those group of people, the OSA, when they have OSA, it has a strong association with insulin resistance. And in some studies says that the insulin resistant groups were present only in the obese women with PCOS who had actually diagnosed with OSA. As you know that obesity is a common finding in PCOS, it's about 88%, right? As mentioned by Dr. Hunter just now. And the obesity in a non-PCOS group, particularly the central obesity, also carries a significant risk factor in developing OSA. Above all those, actually, if you treat OSA, if you detect in the first place, and then you treat the OSA effectively, there will be an improvement in insulin sensitivity and metabolic measures in both the PCOS and the non-PCOS population. Unfortunately, Malaysia has the highest obesity statistics in Asia. Okay, and unfortunately as well, Kedah state also has the highest obesity and diabetic prevalence or incidence in Malaysia. So we move on for the physical examination. We talk about BMR, we talk about neck circumference, waist circumference, and BP. It is not complete if you are diagnosing OSA without a full ENT examination. The physical examination will include assessment of the upper airway, that will include a rigid endoscopy to identify any abnormalities in the nose, in the nasopharynx, in the oropharynx, as well as in the larynx and hypopharynx. Okay. This is just to show you how a normal rigid nasoendoscopy looks like. This is a septum, This is turbinates, there's inferior turbinates, all of us have it, and there's a middle turbinates. So you can see through here is a normal air passage through the nasopharynx. Conditions that can contribute to OSA is, number one is a deviated nasal septum or a septal spur here, hypertrophy of the inferior turbinate, tumor or polyps in the nasal cavity, and adenoid hypertrophy back at the nasopharynx. And in the oropharyngeal area, macroglossia, there's relatively enlarged tongue, and also tonsils. And you also have retroglossal, where you have a lingual tonsil hypertrophy, and also hypolaryngeal masses. What is a crowded oropharynx? A crowded oropharynx that can contribute to the that can be a narrowing of the airway in the oropharynx is contributed by large and elongated uvula, enlarged tongue, enlarged tonsils that cause a small airway, and high arch narrow palate, especially in the pediatric age group where they have adenoid hypertrophy, and a low-laying palate that cause superior inferior diameter and also the lateral diameter of the airway to be narrowed. So a completion of assessment includes flexible endoscopy and also Mueller's maneuver. In the Mueller's maneuver is done at a clinic setting where the patient is in a sitting position and the mouth closed, and we ask patient to inhale with the nose occluded. This is just another video to show you how the Mueller's maneuver is done in our clinic setting. So the patient is awake in a sitting position. A flexible scope is inserted via the nostrils, and have a look at the scope here. This is at the nasopharyngeal area. It looks okay. We want to look at the lateral diameter as well as the anterior posterior diameter of the airway of the oropharynx. We ask patient to inhale while closing the nose, that is to mimic the stage REM sleep. So you can see there is a collapsing of the lateral airway. And you can see this is the tongue base. You can see it's quite prominent. There is the lingual tonsil, or the examples of lingual tonsils that I mentioned before. Another way of assessing is a drug-induced sleep endoscopy, which is done by giving sedation to the patient, and it's a more reliable findings compared to awake endoscope, because in a DISE, the patient is actually mimic the most possible state of sleeping. So we can tell which part of the airway is actually collapsing, and that will determine the management, for example, the surgical management. Okay, it's contraindicated in pregnancy and those who are allergic to propofol and midazolam, and also in those with ASA4. So how we do it? We collaborate with the anesthetic team. We do it in the general OT, where the patient is actually monitored closely. We use a bispectral monitoring where we actually monitor the level of sedation. So it's just like a Mueller's, but at this time the patient is sedated. So the obstruction level is identified, and then we can plan the surgical management for this patient. And last but not least, for the clinical assessment is polysomnography, or what we call a PSG, or sleep study analysis. We subjected the patient to be admitted. It's an overnight sleep study. If you want to have a full parameters that's being recorded and analyzed, it is actually a gold standard to diagnose OSA. Okay, it's quite expensive and it's also time consuming. And in our center, we have a team, we call a burung punggut team, whereby the paramedics are trained to learn how to actually put on, or you call it a hook on the cables and the semua parameters for the patients. They went for a training, and they also went for a training to observe the patients while they are sleeping throughout the night. Okay, so they are very well trained, and they are also trained how to read how to analyze or how to clean the data of the PSG. So this is the examples of PSG. This is done in the old hospital lama dulu, and now it's in a new hospital. This is the graph for the PSG. It's rather busy here. Saya pun kadang-kadang just whip through and look through the summaries of the diagnosis. So in a PSG, the readings for RDI or Respiratory Disturbance Index, that is a mean number of the apnea and hypopnea index, will quantify the severity of the OSA. In a mild OSA, it is between 5 to 20 RDI, moderate 21 to 40, severe more than 40. Some centers have a different reference number, but it doesn't lari banyak sangat lah. Yeah? And in the pediatric age group, actually, if you have the RDI or AI and apnea index of more than 1, is also considered a very significant. Yeah? So simplified the PSG. This is the airflow. This is the respiratory efforts. Yeah? In obstructive apnea, there is no airflow because it's obstructed, but there is a respiratory effort. In a central apnea, there is no airflow because there is no respiratory effort at all. And you can get a mixed situation where you have both obstructive and central apnea. So usually central apnea, we refer to respiratory medicine, and these are the causes of central apnea. So the management plan for OSA is mostly is non-surgical modalities, and only selected patient that we subject the patient for surgery. Yeah? Among the non-medical modalities, of course, weight loss, all the weight loss plan by Dr. Shafinas just now, and then the sleep hygiene, yeah, and then pharmacotherapies, especially those who have allergy symptoms, who have obstruction over the nasal cavity, and the gold standard is nasal continuous positive airway pressure, or rather CPAP, we abbreviated it to, and also oral appliances, which is managed by the OMF and dental. So sleep hygiene, how do you know your sleep is clean? Avoid moderate heavy alcohol, avoid nicotine, do not go to bed in a hungry mode, cut down caffeine. All those things actually will improve your sleep hygiene. Yeah? And CPAP is actually a mechanical breathing assistance whereby it actually splints the patency of the airway rather than giving or supplying oxygen as what many patients actually think of it. And it gives a continuous positive airway pressure, a single level of pressure, which is titrated during the CPAP trial, and it leads to the continuous patency of the airway. Yeah? Okay, so but the limitation with CPAP is not many patients actually comply to it because of you imagine yourself sleeping with all these things covering your face. Yeah, so it's a bit difficult actually, and patients also have dry nose and dry mouth because there is a continuous pressure, a positive airway pressure that has been delivered to our airways. Yeah? But somehow the rice lot rather comply to it. Oral appliances managed by the OMF and the dentist, and it also helps. For surgical modalities, as I said, not all patients diagnosed with OSA is subjected for surgery, only a very selective patients, mainly to treat the obstruction itself, or also to help with the compliancy or increase the compliancy of the use of CPAP. Because imagine you have a deviated septum, imagine you have a polyp inside the nose, when one you use CPAP is going to be difficult. Yeah? So these are the examples of operations being done, and it can be done. Yeah? And Tracheostomy is one of the last resort to bypass all the areas of obstruction. Of course, it will be 100% effective as it bypasses the obstruction. It's indicated as a temporary procedure during an airway reconstruction, or is it permanent in a severe OSA when CPAP is refused or ineffective or is not tolerated, and in other conditions that exacerbated by the apneas, and there's lack of social acceptance to it. Okay, so I come to the end of my talk. OSA is underdiagnosed, and not many of us actually appreciate it as a disease. OSA also carries the burden that it has caused accident-prone road traffic accident. At the moment, the Malaysian legislation has not actually put it in the book about the lorry drivers, the bus drivers, all the public transport drivers to be screened whether they have OSA or not. Yeah? Marital disharmony, of course, you wouldn't be like to sleep with a partner who snores a lot. Social ridicules among the pediatric age groups, even the teenagers. Consequences of it, hypertension and cardiovasculars, and absence from work, yeah? And also performance at school or at workplace. With that, I thank you.